Well, good evening, everyone. Welcome back to our exam pro webinars for the 21 IBOG oral board examinations this evening for Tuesday, September 28th, 2021, our second to last session of the month of September. Since it's Tuesday, we'll be getting right to our case list reviews for this evening. Thank you to all of you who have signed in, and to those of you who have already raised your hands, I'll be with you in just a moment. I think everybody is good on audio, so I'm just going to run through this real quick. And we can get right to our webinars. Thanks. Right. We have a case list up, and I think, as usual, Dr. Minks and Dr. Guardado had their hands up first. And let's go with Amanda first for just a second. Amanda, just trying to unmute you here for a minute. If you can hit your unmute button.
Hi, can you hear me?
Hey, there you are. Gotcha. Thanks. Let's see. Let me find.
I should be there somewhere.
Oh, you're right here. Gotcha. Thanks. Alrighty, we're ready to go. Anything particular you'd like to look at this evening?
Maybe office practice?
Sounds good. Let's see, let's pop into office. Any particular place on your office list, or just?
No, whatever you decide.
Okay,
Dealer's
sounds good.
choice.
Sounds perfectly good. Let's see, can we do, just sort of landed on perimenopausal and menopausal care for case 10. So maybe let's talk about this one for a minute.
Okay.
Let's see, so 61-year-old, she is postmenopausal and looks like she's just having a regular annual examination. If at age 61, her complaint is that while she's been menopausal maybe for several years and has actually felt very well, she's suddenly having really disturbing vasomotor symptoms. What would you discuss with her, and how would you begin to approach sort of evaluating her complaint?
Sure. So I would obviously want to get a detailed history and physical to learn more about her symptoms and her presentation. With my history, I'd want to know, what her symptoms are exactly, when they started, how often she gets them, how they've been affecting her quality of life. I would want to know when she went through menopause, or is she, or how long she's gone through menopause, what other treatments she's tried. I'd also want to do an otherwise detailed medical and surgical history and a detailed GYN history as well. Make sure there's no, and just evaluate for any other possible causes of her symptoms as well.
What other possible causes might you think of?
I think most likely it is probably vasomotor symptoms related to menopause, but I mean, she could have hyperthyroidism, for example, that could be causing hot flashes. I'm struggling to think of anything else right now off the top of my head.
Okay. Well, I mean, she's 61, and maybe she's been menopausal for at least 5 or 6 years. I think you're thinking along the lines, why might she have been feeling well, and then these symptoms sort of turned up all of a sudden?
Right. I would also want to know if she's on any sort of new, like medications, any new exposures.
Good.
Anything like that.
Okay. So aside from thyroid disorders, if we're making a list of maybe sort of primary care topics or conditions that might be responsible here, anything else you might think of that we do run into more in people who are in their 60s or 70s? Thyroid disorders, definitely, as we get older.
From vasomotor symptoms in people in their 60s?
Yeah, sure. Yeah, having hot flushes and night sweats, too.
Possibly like a malignancy potentially could present this way.
That's actually, that's a consideration, you're right. Yeah, what else, maybe?
Any sort of, this is also very likely not specific, but any sort of like a infectious process as well. And then it could also be,
So in a 61-year-old menopausal woman, what infections might you be thinking of?
I mean, I guess COVID-19 potentially could cause.
Yeah, you've got it right there on the list. That's true. These days, yes, you definitely would have to think about that.
I'm struggling to think of any specific ones. Maybe
Okay.
like an infection like TB could cause some symptoms like this. It's
Okay.
very rare in the
Yeah.
United States, but maybe,
That'd be rare. Yeah, we think.
yeah,
But the reason
maybe
they
like
bring
a
this up
travel
is
history.
this is they when examiners do this, they're just interested in how you're thinking because this is something you
Mhm.
probably weren't thinking about when you put this case on the list, and it's
Right.
something that does happen a lot. People come in and they'll have it, so they're interested in sort of common your ideas about common things. You're right, and when you say infections and they ask you what infections, I think the next thing to think of, well, in a 61-year-old woman, what would be common infections that she might get, and just sort of list a couple of those.
Like a flu, a
Yeah.
URI,
Yeah. Right. Yeah. Upper respiratory infection. Sure. What else, mate?
a viral gastroenteritis,
Sure. Okay. Yeah.
community acquired pneumonia,
Sure. You bet.
UTI.
UTIs. Yeah. I think we've got them. They're really the respiratory and urinary and maybe GI. Right. That big covers. Yeah. Now when we're thinking about sort of endocrine disorders, thyroid disorders come to mind. Any other prominent endocrine disorder that we might want to think of?
Hmm. Um, I mean, thyroid is obviously the first one that comes to mind.
Yeah. Sure. Yeah.
I'm having trouble thinking of another thyroid or another endocrine issue that would cause these
Hmm.
specific symptoms, to be
Well,
honest.
but I mean, what's the most common endocrine issue you can think of?
Like
That's what
diabetes.
Yes, diabetes. Exactly. Yes, exactly. Hyperglycemia, hypoglycemia
That is
fluctuations.
true. Yeah,
That's
that's
what
true.
absolutely yes. So I would say I would think that I think the way to go is to think about what's common in 61-year-old women that might now be becoming manifest. So hypertension, diabetes, thyroid disorders, heart disease. Is she getting? Is there an arrhythmia? That kind of palpitations. I mean, that can also cause symptoms like this.
Mm-hmm.
Infectious etiologies, right? Respiratory, postmenopausal women, respiratory, urinary stuff, community-acquired issues, gastroenteritis. You definitely would want to mention COVID. You already got a really nice list there, and the examiners then might just pick one and sort of take a left-hand turn and go off there.
Mm-hmm.
Let's go another one. Let's go a little bit more GYN though, since we've
Mm-hmm.
explored primary care. I think a little bit here. So if in working this up, it really seems that these are actually they're related to her menopausal state. How would you determine whether she is an appropriate candidate to recommend menopausal hormone therapy?
Mm-hmm. So there are actually only very few contraindications for hormonal therapy. Like if the patient had a
Yeah.
history of blood clot, has a
Hmm.
history
Good.
of breast cancer, I wouldn't recommend HRT. If she has unexplained, vaginal bleeding, I wouldn't recommend
Hmm.
it. But assuming the patient doesn't have any contraindications, then I would discuss with her about potentially starting it.
Hmm. Okay, sure. How do you feel about that in a 61-year-old?
Well, there's really no upper limit for when you would stop it. Of course, you want to use the lowest amount for the shortest time possible, but
You do,
every patient
yes.
is different.
Hmm.
And if the patient's having symptoms and has no contraindications, I would be comfortable starting it.
Right. Now, you said there's no upper limit. If she were maybe 70 years old, would you still be okay with this?
I mean, ideally, I would like to stop by age 65, but per
Okay.
ACOG, you don't necessarily need to if they're still symptomatic.
That's true. That's true. But I would be careful, a little careful about the upper limit because when they took apart the WHI study, which is what they'll
Mhm,
then want to talk about with you here,
mhm.
is that when they stratified it, really it is 65 and over is where we start to see risk start to outpace benefit as far as
Okay.
particularly cardiovascular disease risk. So at
Mhm.
61, yeah, at 67, 68, maybe be more careful. Look at her personal
Right,
family history really well.
right.
And final question: if she decides to elect HRT, what type of sort of an administration or regimen would you suggest for her?
I like to do a transdermal patch for estrogen
Mm.
administration because it's associated with a decreased risk of thrombophilia with
Hmm. Of,
uh,
of, of VTE
oral.
events, yeah, yeah.
Yes, sorry, I misspoke. With VT events as well as oral progesterone as well for endometrial protective benefits.
Sounds good. Good deal. No, and there are also combination patches, estrogen, progesterone patches. Would you be
Yes.
okay with those? Good. That's right. Transdermal is sort of the way they'd want us to go. Perfect. Good. Amanda, thank you for that. We sort of did a serpentine and we came back to something GYN at the end there. Anything you'd like to talk about on that case?
Do you think so? I know with HRT there are a million different formulations, and most
There
of the
are.
time when I pick it, it's based off of the patient's insurance, for example.
Sure.
Do you think that they'll expect us to know a ton of different regimens, or maybe like
No.
our favorite
The,
one?
the important ones to be able to talk about the ones you use in your practice. So if you have, if you have a combination patch or you use an estrogen patch transdermal and then you do an oral progesterone, that's perfectly fine. Also, just I would know the one or two that you use, and that's all they. As long as you can talk intelligently about those, you will be fine. Absolutely fine.
Great. Okay, thank you.
Good, Amanda. Thank you very much. That was actually great. Let's jump around here, maybe to Dr. Azada for just a minute. Nasri, trying to get you unmuted here. While I'm waiting for that, I'm going to go back to our case list here for just a minute if I can.
Hi.
Hey, we got you. Hey, welcome. Thanks for joining us. There we go. Got your case list right here. Anything particular you'd like to talk about? We're ready to go here.
No, whatever that you pick, I'm fine with it.
Okay, let's see. Maybe we'll go office practice. Maybe we'll go OB for our next one, if that's okay. Let's see. While we're looking at this, have you been looking through your OB list and have seen any particular topic you'd like to do a little work on this evening?
No, just it's on you, whatever you pick, because I haven't reviewed the case list, so whatever you pick, I'm good with it.
That's fine. Okay. Can we do number 3, cerclage, right here, just because it's staring us in the face. We've got a 35-year-old gravid 6 pair of 1 at 14 weeks. It says history of second trimester loss. The examiners would see this case, and if they decided this would be a really good case, I think if they wanted to talk about cerclage and cervical insufficiency, because it's sort of undefined at the moment. And what they would ask you is, when your patient comes in this case and tells you that she's had a second trimester loss, how do you determine whether specifically she is an appropriate candidate for a cerclage?
So first of all, I ask a very detailed history about the time that she went to the labor and if she had pain or she broke the water. So I try just to get out of the patient what was the cause for the loss.
Okay.
Obviously, painless dilation, it's a sign of the cervical insufficiency. So, and it's a good sign that probably she needs a cerclage.
Okay. So can you tell me just what specific 3 or 4 questions would you ask her to try to determine sort of where this might have come from?
First of all, the gestational age that
Yes.
she had the loss. Second, if there was any other reason for the loss, like any chromosomal abnormality or any other issue that it caused missed AB or delivery. The third one is that if she had any pain during labor, or that's important to know.
That nicely said. Anything else you might want to ask her that might sort of help to determine this? You're doing great. They'll sometimes just want to push you a little bit further.
Sure. If she had any sign or symptom of the rupture of membrane or infection that caused a contraction.
Sure. Now, would rupture of membranes by itself sort of take this out of the category of possibly a cervical insufficiency?
I do
or
not
not?
think so.
No, I don't think so. No, I think we'd be okay there. Yeah, because the rupture of membranes may have occurred because her cervix actually had dilated by like 2 centimeters or so. So that could already happen. Yeah. Anything else you might want to ask her that might sort of help you to nail this down a little bit more? You're actually doing very nicely.
Did you have any history of the cerclage in the past?
Yes, had this happened, very good. Had this happened in a previous pregnancy. And the other thing I was thinking of, has she had any recent office visits where they might have done an exam and sort of identified maybe that her cervix was not effaced or dilated, and then this turned up, and that sort of helps to kind of hem in. So you're right, history in a previous pregnancy and history of her care and evaluations in this pregnancy are actually really important. So in that case, so I'm assuming you're doing a transvaginal cerclage on her in this case. What are the important things you want to tell the examiners about how you care for a patient after a cerclage placement? What's your prenatal care and what are sort of the important aspects of it?
First of all, for patients that they get a cerclage, we need to start them on IM progesterone because of the history of the short cervix. Weekly IM progesterone, and the second thing that I do right after the cerclage, I usually start them on indocin or indomethacin. I give the 50 milligram after the case, and then 25 milligram every 6 hours for 24 hours.
For 24 hours, got it, good. And you said you're using intramuscular progesterone. You're talking about the 17-hydroxyprogesterone?
Yes, yes.
Okay, is that a standard part of your practice?
Yes, I guess it is what it has been recommended, to my knowledge. by ACOG.
Okay, it can be used for people who've had a previous premature delivery. In this case, I'm not aware of a specific. Within the most recent practice bulletin, which is prediction and prevention of prematurity, talks about this a bit, and they are really equivocal on the 17-hydroxyprogesterone. I did not see in there that they specifically recommended it for cerclage placement. I think they're kind of going back the other way. So in the exam, it's important to tell them sort of what you do in your practice and how you work. But I think that practice bulletin, which is only about a month old at this point, was really pretty high yield for the examination, because it talked about sort of the uses of vaginal progesterone, and it started to talk about how they're balancing, I think, their way maybe just a little bit away from the idea of the muscular progesterone, and they may restrict the indications for that. So that's a practice bulletin it'd be good to be familiar with. So we talked about sort of acute management. You give them indocin, and you would, in your practice, be giving them the intramuscular progesterone. What else? What other things might you want to tell them are important parts of how you'll take care of a patient after she's had a cerclage? For the rest of her pregnancy, how's her prenatal care different otherwise?
So obviously the pregnancy is going to be high risk. It's going to be more frequent care.
Yes, there you go. That's important. Yeah. Good. Keep going. Yeah, what else?
Obviously, because of the cerclage, so we need to watch out for the preterm. We need to make the patient cautious about the contraction, rupture of their membrane, or vaginal bleeding for the risk of the preterm delivery.
Sure.
And yeah.
Good. Do you do vaginal or cervical examinations on any particular interval during pregnancy in these cases?
Oh, routinely during the prenatal care? No, yeah. We don't do it.
No, that's fine. I don't believe there's any particular recommendation for that. So how would you plan delivery in this patient then? Since she has a suture in her cervix, what are your plans when she gets to full-term pregnancy?
So usually I remove the cerclage stitch in labor and delivery around 37 weeks, or if they break the water or rupture of membrane or early contraction, obviously I send them to labor and delivery and evaluate them if they are in labor or not. So obviously if they have a rupture of membrane after 34 weeks or cut off after 34 weeks, we remove the cerclage and they can go to labor. So otherwise, if everything goes fine and uncomplicated, we remove the cerclage stitch at 37 weeks. We monitor them for 2 to 4 hours, and if there is no contraction, we send them home.
Good.
With precaution.
Good. And then what's your management after that?
So we just watch them whenever that they go to labor, obviously. We give them the precaution for the labor, contraction, rupture of membrane.
Good. Right. Yeah, we can treat them sort of as normal full-term pregnant ladies at that point. Exactly. Good. Good. Well done. Actually, we sort of drilled into that a little bit. So nicely done.
Thank you so much.
Anything particular you'd like to ask or talk about that just while we have a minute or two before we go to our next case?
I guess I'm fine. Thank you so much. I prefer other and then get a chance to go through the mock oral as well.
Oh no, that's good. That was nicely done. We got
Thank you so much. Thank you.
Thank you. Let's go to Dr. Minks because I know she's definitely waiting. Hey, Abby, thanks for joining us. Can you hear us okay?
Yes, thank you.
Hey, let me get you. You're right here. Let me get your case list up. All righty, your choice. Anything you'd like to talk about this evening?
I have a case, my GYN list that has been, I've kind of wanted your opinion on.
Sure.
It's case number 65.
Got it right here. Okay, under abnormal uterine bleeding. All righty.
Yeah.
Got it. Let's see.
Yeah.
So 42-year-old, okay, AOB, complex hyperplasia with atypia, so it sounds like EIN, okay, and robotic assisted by SO and a cystoscopy, great, and we got adenocarcinoma, not uncommon in cases like this, great. So what questions do you have about this case? That's a very nice described case, by the way. Your level of detail and just sort of your succinct, concise but useful just description of the case is very good here.
I was just, kind of trying to prepare for if, because in this particular case, I did not have gyn-onc.
Right.
and I didn't do a frozen. And in my area of practice, the gynocs in our area, they want cancer proven. They want us to send them like cancer proven cases. And so for me doing a frozen section, even if it came back negative, that doesn't always mean that there is no malignancy. And as a generalist, I wasn't about to go do a lymph node dissection.
Right.
So it wasn't going to change my personal management. So in this particular case, you know, and I did counsel the patient preoperatively that there is a risk of underlying malignancy. And unfortunately, in this particular patient, it did come back, you know, at least stage 3.
Yeah. Yeah.
So
Right.
it was a lot different than my in-office endometrial biopsy.
Yes.
So
But that does happen. So first of all, they would ask you, since you brought up the patient counseling, if the patient asked you, is there a percentage or a number you'd give her as far as when we have EIN in a woman of this age, what percent of the time do we find a coexisting or underlying carcinoma?
I usually tell them somewhere between 25 to 30%.
Right. The textbooks say as high as 40%.
As high as 40%.
Yeah, it's as high, not always, but as high as 40%. Yeah, in this case, that's sort of the kind of established one. But yeah, it's in a range up to 40%. So right, so that was when you were describing this case. That was the question I was going to ask you. So in the exam, you'd want to describe sort of how you understand the current recommendations for how this would be handled. And it really is that we should be referring them to GYN oncology, exactly because there's a high likelihood that we are going to find an underlying carcinoma. And then she has a one-stage procedure with her lymphadenectomy and all that. And if it's all done at once, the tissues are handled better, her care is overall better. But in that case, this wasn't done. So this is a great example of a case where I think let's practice for a minute on how we're going to discuss. You're going to discuss how you understand the current standard of care recommendations are for handling this case, and then why in this case it was handled differently, which is basically that you did the procedure and she didn't get a staging procedure. So it sounds to me like you're going to be comfortable saying, you know, I understand that these cases, these should be managed by GYN oncology, and here are the reasons, sort of one procedure, staging procedure done in all of these cases. So in this case, particularly, why was it that you ended up being the one doing the case?
Because in the discussion with our oncologist, our gyne oncologist, they wanted cancer proven biopsies sent to them.
So your GYN oncologist is specifically instructing you to do it in a way that's different from the ACOG recommendations. In other words, your GYN oncologist is saying, I don't want to be the one to do this one stage procedure. I want you to check it out on the chance that, you know, she doesn't have cancer, and then you send it to me if she has cancer. Is that the way it works in your community?
Correct.
Which is that's exactly what you want to let the examiners know, because that definitely is that's sort of a departure from standard of care, but that if you in your community, depending on your resources and sort of, you know, how busy they are and who's referring to them, they may have set this up and you're following the recommendations. So then the next thing is, then since you're going to do this case and you've already told them you recognize the likelihood of cancer, how do you, during this case then, how do you sort of conduct an assessment as for whether the patient might have carcinoma in the course of doing your robotic hysterectomy?
Well, of course, when I enter the abdomen, I'm going to inspect, you know, the peritoneum and the abdominal cavity to see if there's any evidence of malignancy or things that may require, you know, a biopsy if I need to take a biopsy.
Good. I like that you're starting at the very beginning of your surgery. You're doing great. All operative laparoscopy procedures like hysterectomies begin with the diagnostic laparoscopy. That's an important concept. Yes. Then what else during the course of the procedure? Do you do any particular tests or studies during the procedure to assess for whether carcinoma might be present?
You can do peritoneal washings. In this case,
yes.
In this case, I did not.
Okay, well, I think in all cases in which we suspect neoplasia, we should. So I think if you don't have to, in this case, you don't have to say, you know, I usually, you know, we could, but I didn't. I would say in cases like this, it would be considered appropriate to get peritoneal washings and leave it like that. And likely they will not ask you, well, did you? They'll just take it at face value. And that's because that's important. That's after looking around. I think that's the second thing we should do is we should do washings. Yeah.
Okay.
Otherwise, you brought up frozen section, and that's where I kind of wanted to see if you would go. Would you what's the utility of frozen section for you? How does that help you, or maybe not, in you doing this case?
It doesn't help me if
Right.
I don't have a gynonc because I'm not
Right.
going to do no
Exactly.
dissection.
Yes. So you mentioned frozen section when you were first starting to talk. In cases like this, do you obtain a frozen section, or do you consider that?
I would if I had say a gynonc on standby
Yes. Right.
to do a lymph node dissection. Yes.
Yes. But in cases like this, you generally don't, right?
Correct.
Good. So coming back to the question, in cases like this, would you do frozen section assessments?
No.
Good. That's the safe answer that I think you should give, because the utility of it is, you're right, it's very variable. It may or may not actually pick up carcinoma. We don't necessarily stage it. Our routine formal histology is way more useful, and you got, if you read down your surgical pathology diagnosis, you got a huge amount of information from your formal histology. You'd never get any of that stuff from a frozen section. So
Right.
you're right. The correct answer in the exam, if they ever ask you about frozen section, is, unless I can think of a particular way how it will change my management of this patient right now, this minute, no, I will wait for the routine histology. That's the conservative and best line to go on. Exactly right. Good. So
Okay.
then the only question they can ask you, because you've done a very nice job with this case at the end, then is, so you discovered here that she has grade 2 adenocarcinoma, and it does look like it might be stage 3. So you're obviously going to send her to GYN oncology. What would you expect the GYN oncologist to do as their next step?
Well, they could potentially take her for a second surgery to stage, or they could treat her as at least a stage 3.
Yes.
In which case she would then need chemotherapy and radiation.
Yes. True. Exactly. Yes. You've done a good job, because you removed all the important organs and tissues, except we didn't get lymph node staging. And depending on how important it was, they might actually, you definitely go into adjuvant therapy, chemo radiation, and then they might go back later, perhaps, and do that. But you're exactly right. That was well said. That the GYN oncologist will make the decision as to whether to reoperate or to go to second line treatment, because clearly it is metastatic. It's widespread cancer at this. And that's all you need to know. This is only the generalist boards. They ask that question to sort of see, sort of what more broadly about how these cases might be done. If in answer to that very last question you said, I'm not sure, I'd have to ask the GYN oncologist, you would be fine. They'd go off and talk about another case. There would be no points lost for that, because that's not stuff you have to know to take safe care of your patients. That's what the oncologists do.
Okay.
Good.
Okay.
All right. This is a good case to walk through, particularly because we're always looking for cases in which the patient's management was sort of a departure from the standard of care, and sort of always thinking about how to discuss that in the exam and how to defend it and how to show how it was the appropriate in this case. And I think you've done that very nicely. You've described your sort of, the constraints under which you operate and what you're doing in taking good care of your patient, and also helping your gynecologic oncologist. Great. Thank you. That was a really good case. Thanks for doing that with us.
Thank you. Sure.
Let us move right along, because we're doing very nicely for time here. Let's see. Let's go to Dr. Dykes, maybe. Bethany, I'm going to try and unmute her for a minute, and we'll get back out to cases.
Yes. Can you hear me?
Hey, yeah, you're good. Thanks. We can hear you just fine. Let me just run to your case list. Do you have your case list up here with me? I'm running by.
Yes.
Oh, I'm sorry.
Yes,
It's right here. I'm sorry. I just walked right past it. All right, good. Ready to go. What would you like to look at this evening?
Maybe just a case off the office list.
Office list, sure. Any particular case on office?
No, any of them is fine.
Okay. All right. Let's see. Let's go for something we haven't really talked much about this evening. Let's just see here. ABC. Let's see. Let's talk about case number 14 here, an 18-year-old with dysmenorrhea and dyschezia. And I'm going to that because we have sort of had reports in the past 2 years on the exam that stool issues, stool incontinence and dyschezia have turned up in structured case questions. And there was an incontinence practice bulletin that sort of touched on it, and I think that triggered it. But just in case, we should probably talk about this. So
Okay.
we could do this as an 18-year-old, or we could make her 68 years old. Do you care one way or the other? Because in the office practice cases, that's what they do very characteristically. Half the time they'll make your patient a generation older or a generation younger just to talk about what they want to talk about. So it's hard to study for your office practice cases in the way that we normally do. But the important thing to keep in mind is they do that all the time. So
Okay.
when all of you are studying, remember that. Sort of practice your cases, then move them a generation and think about how you talk differently. So I'm sorry, go ahead, Bethany. What do you want to do?
Sure, you can change her to whatever age you feel fit.
All right, let's make her 68, because in 18,
Okay.
there's not much to talk about aside from, I think, endometriosis. So 68 years old, comes in because she is actually experiencing progressive pain with passing bowel movements, maybe several weeks or so. Never happened to her before. How would you begin to evaluate that on an office visit?
Yeah, so first I'd want to start with a detailed medical history, including her
Yeah.
past medical history, past surgical history, trying to really assess if she's had her abdomen entered previously in the past. I would
Okay.
also want to get a good idea of what medications she's on, any GYN history as well, like how long has it been since she's been in menopause, how long has it been since her last pap smear. And then I'd want to do a thorough physical exam, especially in regards to her abdominal and pelvic exam.
Mhm. Okay, now that's all fine. And so you talked about how you evaluate pretty much any patient who comes into your office with a GYN complaint, but specifically for a complaint of painful bowel movements, what the examiners want to hear, rather than the general GYN history, is maybe what are the 3 or 4 questions you would ask her that are most important to you? And on the physical examination, maybe what are the 3 or 4 things that you're going to do on the exam that really help you to address this problem?
Okay, so I want to know a little bit more detail about the specific pain that she's having. Is it just with bowel movements, or is it not just with bowel movements?
Good.
Is it like a constipation or straining pain, or just get a better idea in general on what type of pain it is she's describing?
Good.
On her physical exam, I would want to do not just a bimanual exam, but also a rectal exam, of course, and evaluate for any masses or anatomical abnormalities that could be palpated.
Okay. So let's back up for a minute. Could you do maybe a brief differential diagnosis in a 68-year-old who comes in with this complaint? What would be maybe the top 4 or 5 things on your list?
I would be concerned for colon cancer, especially if she was having any bleeding in the stool. That would be concerning.
Okay.
Um, I would also just be concerned if maybe she did have a GYN issue, something like a pelvic mass, an adnexal
Yeah.
mass, a
Good.
fibroid, something that's pressing on the area that could be causing discomfort for her.
Mhm. Okay. Got a couple there. Now, those are among the more serious and dramatic things that are going on. But there are things I have a feeling that are much more common. I think the average 68-year-old who came in who would be describing this to you might have something that's probably not as particularly life-threatening. Can you add maybe a few things to the list that might be
Sure.
kind of more benign?
She could just be having hemorrhoids or an anal
Yes.
fissure.
Exactly. Let's start there. Hemorrhoids or anal fissures are probably in an older person who's tending more toward constipation. It's certainly probably having some sort of, with age-related thinning of tissues in the genital area, and that can be sort of vaginal mucosa musculature and also in the anal area. Sure. So I think hemorrhoids or fissure would be a great place to start. Going from there, can we maybe do something between there and the colon cancer? Add a couple things in. Just any other thing. And I like very much, by the way, you're going to the GYN. I think we should always think about there's an integrated sort of compartment of the lower urinary tract, lower genital tract, and GI tract. And so painful bowel movements, one of the questions I would ask her is, are you having pain with urination? Are you having pain with intercourse? We're sort of looking into all of those other compartments, and anything weird and different symptomatically otherwise. Anything else we should think of as far as differential diagnosis? Pain with bowel movements in a 68-year-old.
If I would want to know if
Benign,
she's had
non-malignant. Yep.
okay.
Non-malignant.
Like diverticulitis,
Yes.
or osis.
Another really good one. Yes, exactly. Diverticulosis. That actually sounds great. Good. I think that'll probably get us there. If you add in anything else that's not malignant, anything else you might throw in there. We're thinking about just basic categories of sort of lower GI issues.
Like a colitis.
Yes, very good. Inflammatory bowel disease, which could be a colitis of various sorts. It's not likely you'd suddenly develop UC or Crohn's, at the age of 68. That happens earlier in life, but we want to definitely do efficacy. That's actually great. So now going back, I think starting there and going back, any other questions you'd like to ask her that you didn't mention before? And on the physical exam, anything else you'd want to check that you didn't mention before, just in case you want to fill in any blank areas.
I think asking her if she's had changes with her bowel movements, like pencil stools,
Very good. Yes.
bleeding with the bowel movements. And then, like you mentioned, I would now want to add in the pain with urination or pain with intercourse besides
Sure.
just bowel movement.
Just to see. Yeah, good. As far as history, is there anything else that you would want to know about this? When we were talking about the cerclage issue with Dr. Zada, one of the things you mentioned is, have you recently had an evaluation sort of where, where something is found to be normal and now you're having symptoms? That's a useful thing to talk about in the exam whenever you're working with a problem that's sort of a recent onset. So is there anything you might want to ask her about sort of recent exams or evaluations she might have had that you could use as a reference point if you're going to start to work this up?
Sure. Like if she's had a recent colonoscopy would be really helpful.
Exactly. Have you seen your primary doctor and you had a rectal exam recently, and have you had a colonoscopy recently? Perfectly, or anything else. Good. Great. So if it seems, if your examination is sort of non-focal and you're not really finding anything on your rectal exam or pelvic exam that elicits pain, but she is having progressive pain with bowel movements, we'll wrap up here then in a minute. What test would you order? We'll make that our last question.
A simple test for her could be like a stool Guayat card, like to see if she has any fecal occult blood would be a good starting point.
Yes, and
I'd certainly,
yes, go ahead.
I certainly want to get her referred to GI since if I couldn't find anything on my exam, I would want them to be at least following along to see if they could work her up for anything that I couldn't find.
Good. And what tests would you kind of want them to do, or would you figure that they probably would do?
Besides a physical exam, I would certainly hope that they would order a colonoscopy for her.
Yep, exactly. Yes, colonoscopy and sometimes a CT with GI contrast to sort of look for that. You often can pick up sort of stuff on the outside of the colon, colitis, other diverticulitis issues and things like that. Yeah, that sounds perfect. Good. So that's just pain with bowel movements. It's really just, it's sort of just in your mind, sort of making up the differential diagnosis. And when the examiners ask you, how would you begin to evaluate that? Feel free to start with the differential diagnosis and say, well, the things I'd be thinking of, and just list them, write them down on paper in front of you. And once you have that, it's really easy then to think about what questions you would ask and to think about specifically what you'd look for in your examination, sort of covering your bases. And it gives you structure to help you to move through the exam. So that's always a nice way to do it. You don't have to answer the question they ask you. That way you can start by making up a differential and then take it from there, and you'll give them everything that they want.
Perfect. Thank you.
Very nicely done. Good. Thank you. I'm glad we got to do that. Excuse me. Sorry. Let's move on. Let's see. Maybe Dr. Tran. Let's see. Linda, I'm going to try and unmute you for a minute. We'll get back out to the cases here for a moment. Oh, good. Linda, hi. Are you there? Can you hear us?
Yes, please.
Thanks. Let me get down. There's your case list right here. Anything particular you'd like to talk about this evening?
Nope. Anything you want to choose.
Okay, let's see. We have hit, OB and office and GY. Let's see, maybe go back to OB again. Let's see.
Okay.
Let's do that. Just kind of cruise down into the list here. We'll see if we can find something interesting here. Just to pick something that's always good to go back on, especially because there's a very recent practice bulletin on this. Repeat cesarean delivery. Let's do case 43. 33-year-old. She's had one prior cesarean delivery. Says trial of labor after cesarean delivery counseling was declined, so she had a repeat cesarean delivery. Can you tell me, for this patient specifically, how did you counsel her about the issue of TOLAC?
Absolutely. So I followed this patient from the beginning. So I had the opportunity to ask her about her prior cesarean section. I believe it was actually for arrest. But anyway, so she, I still told her that since she only had one cesarean, she is a candidate for a trial of labor after cesarean if she so chooses. I review the pros and cons to both. So the pros of having a vaginal would be faster recovery. If she chooses to have more children in the future, it would be safer, since the more cesarean sections you have, most likely you'll just continue to have cesarean sections. And I also discussed for cesarean, the benefit would be, in case if we do try and she ends up having a cesarean, that would be the second best option. So the best would be if she would have a successful vaginal delivery. Second best would be as scheduled. And then the third would be we try, but she ends up with a cesarean anyways.
Yeah. So given that, and that's sort of the thorny issue, how would you go about sort of counseling her based on what you know about her, about sort of what TOLAC would mean to her? You said you thought that it might have been for a labor arrest or labor dystocia.
Right. So, for example, if I remember right, she actually she was induced and then had an arrest.
Okay.
So I told her, we don't have to choose now. She can, or if she goes into spontaneous labor, which she did at 37 weeks, then if she wanted to, try to TOLAC, she can. But given that she had an arrest, the probability of having a successful delivery might be decreased. But it was also the circumstance of that particular pregnancy was she was induced and such. So yeah.
So you mentioned that the likelihood of a successful vaginal delivery is reduced because she's had an arrest. If she asks you, is there a particular approximate percentage you could give her as far as likelihood of success for her this time if she tried a TOLAC in the setting of a prior
I believe
arrest?
Right. I believe it's 60%. There is a VBAC calculator that's that is endorsed by ACOG.
Yes.
And I would have to recalculate, but I think her probability was about 60%.
That's right. And mentioning the calculator is fine. I think for the exam, it'd be good. This is an important topic. It'd be good to know the very basic numbers. And for a previous labor arrest, or for what we call sort of a recurrent risk factor, which is something for which something about that last pregnancy moves into this pregnancy, sort of the shape of the pelvis, 60 to 65% is a reasonable number. For a non-recurrent risk factor, like breech or placenta previa in the last pregnancy, or twins or something like that, 75 to 80% is reasonable.
Okay.
And if you just know those two numbers and then mention that you use the calculator, that's fine, because the calculator does get more into the patient's individual factors and can kind of tune that number up a little bit more. Good. So just then, final question: in your practice, then, if she had elected a TOLAC and she had a previous labor arrest, do you have particular criteria as to sort of how you would manage her in labor, or particular criteria which you would sort of recommend that she instead have a cesarean delivery? As in other words, as far as sort of what time of the pregnancy goes into labor and sort of what's required for her to labor and things like that.
Right. Certainly, if she went into spontaneous labor before 39 weeks, then that would be much easier. But if she had other risk factors like diabetes, or if I suspected macrosomia, then that would decrease her risk and decrease her chances of having a successful VBAC.
Sure. Yeah. Do you have a particular gestational age, which if she arrives there, you would feel less comfortable with doing TOLAC with her?
If she was post-term, such as 42 weeks, then I would definitely be.
That's fine. They're just interested in knowing sort of how you work this. How do you feel about inducing people in labor for TOLAC?
I do offer it if certainly I would not use any prostaglandins.
Right. Very good.
But I would offer it, like for example with a folded balloon or a Cook's balloon.
Sure. No, good. That's fine. They'll just be sort of feeling you out as to sort of that you understand sort of that you can set up criteria and sort of how do you manage that. And mentioning the prostaglandins, I think that's a really important thing there. Good. Good. No, I think we covered the basics on that very nicely. It's just nice to go back over this because it's a very, very common structured case question, particularly on the exam. Linda, nicely done. You actually you seem comfortable with this. You seem to know your patient well. You seem very sort of facile with sort of laying out how you would counsel her. It was a really nice, just sort of structured discussion. Well done. Is there anything about that you'd like to talk about further or just ask about?
No.
Yeah, that was well done. Thanks for going back over that with us again. We'll do that from time to time. Go to Dr. St. Germain, I think, for a minute. Ashley, I'm going to try and unmute you for a moment and find your case list while we're doing that. Got it right here. Let's see. Ashley, can you unmute yourself? Oh, there you are. We got you.
Hello.
Hi. Thanks for joining us this evening. I have your case list up here. Anything particular you'd like to look at?
No, whatever you think.
Oh, let's see. Can we maybe go GYN? Just because we've done a bunch of office and OB this evening so far. Anything that's been interesting to you on your GYN case list recently?
No, whatever catches your eye.
Okay, let's see. Let's get to something new and different here. Let's see. Let's see. Congenital anomalies of the reproductive tract. I'm not sure we've hit that in a while. 15-year-old. This actually could be a pretty good one. So it looks like this one is, yeah, this would be a good one to talk about. So it sounds like this was somewhere where you had some difficulty in doing an office examination.
Yes, so this patient came to me as a referral from her pediatrician that she had complained about pain with her cycles, with menstruation and inability to use tampons. And similarly, the pediatrician didn't feel comfortable doing an exam, and neither did the patient. So she came to see me with her mom, and we did try an exam very briefly that she tolerated, just like separating the labia and being able to see the introitus a little bit, but nothing like speculum or anything like that. So we talked about, she's able to have she's able to menstruate, but obviously is having some discomfort and some issues. So we could do an exam under anesthesia or kind of wait and see. So she and her mom had elected to do the exam under anesthesia. And from what I could see on the brief exam in the office, I did think that there was a hymenal abnormality. So then we did the exam under anesthesia. She did have a microperforate hymen, so I just did a cruciate excision, and that was it. And when she's come back for follow-up, she's done really well.
Great. When you saw her in the office and the complaint was that it was painful and difficult to use tampons, what might be your basic differential diagnosis starting off?
Well, a hymenal abnormality or using not the correct size tampon, like a not really correct education about it. She could have had a septum. Those are my main differentials.
Sure. Okay. Anything else? And that's a really good differential so far. I was hoping you'd mention the septum. I think that's important because it's not all just about hymenal abnormalities. Anything else that could be going on here if she just has pain with inserting and removing tampons?
She could have vaginismus or even something like endometriosis, although that would be not like a totally classic symptom, but vaginismus or history of abuse, which I didn't elicit that history or anything like that.
Good. I'm glad we looked for that. Good. So if on your exam under anesthesia you had actually identified a vaginal septum, how would you go about managing that?
Personally, I don't have much experience transecting the septum, so I probably would have ended the exam and woken her up from anesthesia and discussed with her and her guardians about sending her to a specialist for that.
Good. Any particular type of specialist you would send her to?
I would try to send her to a pediatric gynecologist, like adolescent pediatric gynecologist or urogynecologist potentially.
Good. And what might be their first step in managing this?
Similarly, I think they would do an exam, and then it can be, typically I would have them get she would likely get imaging, so if that would be an MRI or ultrasound first to see what's happening with that septum.
Yeah. Well, what particularly do you want to know about when you say what's happening with the septum? What would you learn from the imaging?
Well, the exam also should help us know what's the direction, although she was having a period, so we assume it wasn't a transverse, so it was more
Yeah.
likely longitudinal if she
It
was
should
having
be
a period.
longitudinal.
But the location, and then does she have any other associated abnormalities like congenital anomalies such as renal issues or
Very good. Good, exactly. If you had done your exam under anesthesia and anatomically she was completely normal, hymen was sort of absent, the vaginal vault seemed to be normal, where would you go from here?
Same thing, I would have woken her up and talked to her and her mom about does she potentially have a vaginismus, or is this just discomfort in general with tampons? Does she need some pelvic floor physical therapy or dilators or some things like that? For her age, and she was virginal, you know, I wouldn't necessarily go straight to vaginal dilators at that point, but
Right.
something that we would have a discussion together about.
Good, and I think that's exactly the right thing to discuss with her. The question that comes up though is sort of educating her about those options available for treatment would be good. When would you recommend that she undertake physical therapy, pelvic physical therapy? Would you want her to do it now?
For this particular patient, no, because she is uncomfortable with pelvic exams, as was not sexually active. So I think with time, or if she was thinking about that she wanted to maybe become sexually active soon, or was more comfortable with the idea of that, then I would recommend it. But I would discuss that's something that she should really consider, because vaginismus especially can be really debilitating to people's lives. So something that we can definitely try to fix, and I don't want her to wait until she's 40 trying to fix it.
That's a wise consideration. So is there anything else you might recommend, since it sounds like maybe you don't want her to go into physical therapy like right this week, anything else you might recommend as far as maybe another consultation or further evaluation of this?
Sometimes some sort of counseling, like psychiatric, psychological counseling is helpful.
In a 15-year-old who's not sexually active, primary vaginismus, it's hard to figure out why that would arise by itself. I think recommending an evaluation with a psychiatrist and someone who, if we could, maybe is more of a specialist in women's behavioral health issues, would be really useful, just to get more of an idea of where this might be coming from, and that may actually facilitate her then beginning to be able to work on this at some point. I think that's a very nice idea. Good. I think actually you walked through that, and you were looking at the big picture here. That was actually really nicely done, Ashley. Thank you.
Great, thank you.
That's great. I think we have a few minutes for maybe one more case. Let's get maybe Dr. Pham from it. Tiffany, I'm going to try and get you unmuted, and maybe we have like about 5 to 7 minutes. We could do a case. If you can unmute yourself for a moment.
Hi.
Hey, there you are. Thanks. Let me grab. I think you were like down here. Oh, there you are. All right, so let's see. You're the last, I think, case for the evening for us. That's a good. We got to talk to 7 candidates this evening. So your pick. Anything you'd like to talk about?
How about GYN?
Sure. We'll go back to GYN. Anything interesting you're looking at the moment here?
No, anything.
Okay. Let's see. Let's see. Just go here for a minute. Let's see. Can we do case number 12? That next one, problems with that this evening. So 36-year-old got a 6-centimeter 6-inch hematoma of the ovary. In a case like this, when you have what by ultrasound would seem to be a benign neoplasm of the ovary, how do you make the determination of whether your surgical approach will be laparoscopic or open?
If there was any, well, I guess to start off, if there was any concern for malignancy, then I would have her go to gynonc.
Yes.
But most, I would say, if it doesn't look like it's got solid components, most likely we could do it laparoscopically. And remove it through like the umbilicus or a slightly enlarged like trocar site. So usually I go laparoscopically.
Okay. In a case like this, because cystic teratomas sometimes do have solid components. In a case like this, what would you particularly be looking for on your exam and your workup and your review of the studies that would lead you to say, no, this should be an open case? Can you make a sort of a list of the criteria for which you would say, no, laparoscopy is not going to work for me here?
If there, I would say if it was a larger size and predominantly solid components.
Okay. Well, in general, what would be your size threshold for going from laparoscopic to open?
It's certainly 10 centimeters or larger.
Sounds good. That sounds good. They're just interested in your number, and a very common number would be around 10 centimeters. That sounds good. So, right. So I think if it's cystic, 10 centimeters. Now, you said if it were solid, if it were 6 centimeters and solid, how would you approach that?
I think I would still certainly, I think I would counsel the patient that there's a possibility that we may need to convert to an open. But a lot of the time you can kind of potentially put it in put the specimen in an endo catch bag and kind of break it down or morcellate it in the endo catch bag. So I would certainly try doing that before going with a larger incision.
Sounds good. Good. All right. So size and whether it's solid or not. Anything else that would lead you more toward open rather than laparoscopic? You mentioned features suspicious for malignancy, but then of course we would just refer out in that case. Anything else?
If there was, well, I guess if I had concern, well, I guess where I was going with that was if there's concern for like complex anatomy, like a history of adhesions or endometriosis, prior surgeries that would make the case more complicated. Although I think that's kind of a gray area where you could potentially start laparoscopic as well.
Could, but I think that's very important to bring up in the exam because you're telling the examiners that you're looking back over history and you're trying to do all your homework in advance so that when you go to do the operation, you sort of have the best likelihood of doing the right operation first. And if you can go back and get an op note from her surgery 10 years ago where she had, a pelvic mass or cyst or something like that, and it describes just a very difficult procedure, very dense adhesions, difficult to find the adnexa, you would obviously probably go an open procedure, and you'd probably also have somebody more senior scrub in with you just for help. So that I'm not sure it's a gray area. I think that's very important. We should consider those things when we're thinking about planning surgery. I would definitely want to tell the examiners that. I think that was the other thing I was wondering if you would bring up. Good. So we've got size, we've got sort of cystic versus solid components and how well you might be able to get them out with an endoscopic retrieval bag. And we certainly, if there's any concern about neoplasm, you don't want to break it up inside the abdomen. And then, any complicating factors for the operation itself. Let's see, anything else in there? I think, can you think of anything else? Or a couple other things that are sort of way off on the side. And it has to do with things that may be relative contraindications to laparoscopic surgery, like her having a hernia with mesh repair, sort of where you need to put your trocars in or things like that. Which, by the way, that's always good to mention to the examiners, because we do need to think about things. Past surgical history can cover a lot of different things. And
yeah, so if she had like a prior vertical incision, a mesh like repair of a hernia in the umbilicus area, then certainly I would, instead of entering at the umbilicus, I would enter at Palmer's point.
Very good.
Which is like at the midclavicular line, about 2 centimeters below the left rib.
Perfect. Yes, exactly. And that's important to mention in the exam as well. And it's important also because by being conservative, we want to be sure we do the right operation first, but there's always a great utility to doing a diagnostic laparoscopy and using that to figure out then what your actual operation is going to be. And if you can get a small scope in at Palmer's point, you can learn a lot from that that'll lead you toward probably having the least complicated type of operation when you decide which way to go. Very nice. Great, good. Tiffany, thank you for doing that with us. That was actually really nice. And we do have to stop for the evening. Thank you to all of our candidates. We did actually get to talk to 7 people this evening. That was pretty cool. Structured cases, I believe, tomorrow night with one of our other faculty. And then we will move on to October. For those of you who will be continuing into us in October, we'll be getting together next week. For those of you who are finishing up in September, please do get in touch with us if there are questions that you would like to talk about. You can generally sort of send questions in and they will distribute them to the faculty so we can answer them. Do remember you are a subscriber right up until your exam. You can go back, review all of these on podcasts whenever you would like to, just for further study. Best of success to all of you in the exam, but we'll look forward to continuing on after tomorrow into the month of October. Thanks. Have a great rest of the evening, everyone.